Sing together, Father in heaven. Father in heaven, holy is your name. Your kingdom come, your will be done on earth as it is in heaven. Our Father in heaven, lead us not into temptation, but God deliver us from the enemy. Yours is the kingdom and the power and the glory forever. Give us each moment all that we need. Forgive us our sins as we forgive the ones who have sinned against us. Oh, our Father in heaven, lead us not into temptation. Come on. But God deliver us from the enemy. Yours is the kingdom Amen.
Mga kababayan, ang pambansang awit ng Pilipinas.
Kayang mag-ibig, helas ng silanganan, alam ng puso, sa titik mo'y buhay. Lupang hinirang, kuyagan ng magiting, sa manlulupin, di ka pasisigil, sa nagatang tutok sa simoy at sa langit ng pagaw, ay hinatang tula, awit sa pagkayang minamahal, ang isang ng matawad mo'y tagumpay na nag-iindig, ang bituin at araw niya kailan pa may di magtitingin. Luman ang araw ng walhati pagsinta, buhay langit sa piling mo. Ang inigaya ng pagkay mga amin, ang mamatay ng dahil sa'yo.
So I'm Dr. Uson. I'd like to welcome everyone, PGIs, residents, interns, and consultants, and welcome to this lecture series. And we're very happy, and we are fortunate to and honored to have with us two distinct speakers from our Cancer Institute, who will give us lights on the latest on immunotherapy and in leukemia. The first speaker is no less than Maria Suga Dioko. She is a graduate of the Cebu Institute of Medicine and had her residency in pediatrics at Cebu General Hospital. She then proceeded to take her fellowship in pediatric hematology at the University of Santo Tomas in Manila. She had also her diploma on health profession and education at the University of the Philippines. Presently, she is an associate professor of Cebu Institute of Medicine and a practicing pediatric hematology in Perpetual Succour Hospital, Cebu Cancer Institute, Cebu General Hospital, and St. Vincent General Hospital. Our second speaker is also a classmate of ours, Dr. Ellie May Villegas. She is a graduate of Cebu Institute of Medicine, had her residency in internal medicine and fellowship in medical oncology at Philippine General Hospital in Manila. She had her clinical fellowship in medical oncology at the National Cancer Center, Singapore. Presently, she is a director of the Cebu Cancer Institute Perpetual Succour Hospital, the section head of our medical oncology unit, and the past president of Philippine Society of Medical Oncology. So first, we welcome our first speaker on the basics of leukemia. So Suga, thank you. You may share your slides.
Continue. Hi. Thank you, Arnold. A pleasant afternoon to everyone. I'm here to talk about topics, and usually when I talk about something that I'm very passionate about, I have a tendency to ramble. So you can stop me anytime if I go over time. Okay, so I'll show you this. Can't click. Okay, this is just to show you the scope of hematology. We have under hematology, we have bleeding disorders, clotting disorders, bone marrow failure syndromes, red cell disorders, and of course, leukemias, white cell disorders, leukemias. For this afternoon, we'll just talk about this this part. And this is the outline of the lecture. So as the title itself, it's very basic, all back to basic on leukemias. And when I made my objectives, I had the nurses in mind because I thought I will be talking mostly to nurses, not to onco nurses. So these objectives are directed to you, not to me. So at the end of this lecture, I would expect you to be able to explain the basic facts of leukemia, particularly acute lymphocytic or lymphoblastic leukemia. And also, I would expect you to be able to discuss confidently to the patients and parents with leukemia the different procedures, why they are being done, and what are the complications that you may expect. And then I would also expect you to manage appropriately adverse events that may occur during the treatment, just a few. Otherwise, we will not finish. So this is back to basic because I thought I will be talking to nurses mostly. So this is the whole blood. So you have the plasma on top when you centrifuge the whole blood and the cells at the bottom. Okay, so the cellular part is composed of white cells, red cells, and platelets. So this is how it looks like. This is, of course, these are the red cells, and this is the appearance of the platelets, and these are your white cells. Okay, and you have different types of white cells. We have the lymphocytes. We have a T and B lymphocytes. You cannot distinguish them morphologically under the microscope. You will not be able to tell which one is T or B. Now, this is how a lymphocyte would look like. And we have granulocytes. They are called granulocytes because they have granules in their cytoplasm. So wait, I'll remove this one because... Okay, this is a eosinophil for the sake of the nurses. No, this is how a eosinophil looks like. This is a neutrophil and this is a basophil. We seldom see this in the peripheral blood. Okay, and special mention on the neutrophils because I'm sure the nurses know how to compute the absolute neutrophil count. And we use the absolute neutrophil count as our basis whether to go ahead or to defer the chemotherapy of the patient. This is the monocyte. They look a lot like lymphocytes, except they are much larger. Anyway, this looks busy, but I'm just showing this to you so you'll have an understanding why there are so many types of leukemia. Okay, you just have to follow the lines. Okay? It's a common knowledge that we have stem cells in our blood, and some of these stem cells are committed to become myeloid stem cell or lymphoid stem cell. So we'll start with the lymphoid first because it's simpler. Because a committed lymphoid stem cell can only become a lymphocyte. Okay? It can either be a B lymphocyte if it matures in the bone marrow, or a T lymphocyte if it matures in the thymus. So abnormal proliferation of the lymphoid stem cell at this part will lead to acute lymphocytic leukemia. Okay, how about the myeloid? This is more complicated because as you can see, a myeloid stem cell can either become a myeloblast, which will differentiate into your granulocytes, or a monocyte, which will differentiate eventually into monocyte and a mature monocyte. Okay, and it can also become a megakaryocyte, which will eventually become platelets. And aside from that, no, it has another arm, the erythrocyte. So as you can see, all these cells here have a common progenitor. So any abnormal proliferation at this part will lead to acute leukemia, acute myeloid leukemia. But in the more mature part, it will lead to chronic lymphocytic, chronic myeloid leukemia, no, not lymphocytic. Okay, I cannot change. So what is leukemia? Okay, it is malignancy of the bone marrow stem cells. To make it clearer to the layperson, I usually would tell them it's cancer of the blood. And we have different types of leukemia. As I have mentioned, it can either be acute or chronic or lymphocytic or myelocytic, depending on the stem cell or the cells involved. So acute, it's usually malignancy of the early stem cell. It can either be myeloid or lymphoid. And chronic is generally malignancy of cells at the more mature stage. Again, it can either be myeloid or lymphoid. Okay, so I'm a pediatric hematologist. So I'm sharing you the statistics of the types of leukemia in children. So majority is ALL. So we will focus our discussion on this only, and a little of this if we still have time. Because when I timed my lecture before this, it's actually more than 30 minutes. Anyway, so how does a person get leukemia? This is very important to tell the parents because often there are no identifiable factors that can lead to leukemia. So the parents would often ask, no, ano man dok, wala man na sa among kaliwat, no? As you can see, 90% the cause is still unknown. Only 5% will have genetic factors that's causing the disease. Some may have exposure to radiation, but often 90% unknown. So it's very important to tell the parents this because they often have guilt feelings. No, mag-guilty sila. What is it that I did or did not do that caused the disease? So right from the start, you tell the parents immediately nga, it's not your fault. This is very important for the parents. Okay, what are the clinical manifestations of leukemia? So they are related to bone marrow failure. There is hyperproliferation of abnormal WBC in the bone marrow, leading to suppression of the production of your red cells. So you have anemia. It will also suppress the normal white cells. You will have infection and you will have thrombocytopenia. But the important manifestation that I would like to point out here is that sometimes you don't have this yet, infection, bruises, sa salida lang na, that you would see them the mother would notice na naglagom-lagom na. It's only in the movies. Often, the only manifestation that the child has leukemia, bone pain. It's bone pain. That's why often they are referred first to rheumatologists. They are often misdiagnosed as having arthritis. But if there's a takeaway message that I want to impart to you now, no? Bone pain, fever, plus or minus pallor, think of leukemia first. Just to show you some leading manifestations in patients with leukemia, you have petechiae, sobra na kayo na siya. That's, you have hematomas, there's pallor, and sometimes you can't rely on the skin color to detect pallor. So you use your palms to compare with that of the child, the color of the palm of your palms, granting that you are normal. But if you're not normal, ay na lang. Okay. Just to show you a lymphadenopathy, where to palpate for the lymph nodes, here, 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 the inguinal, splenomegaly. So if you can feel a mass at the left upper corner of your abdomen, most likely that's spleen. So normally you can't feel for the spleen, but if you are able to palpate for the spleen, that's already splenomegaly. So how do you make the diagnosis? You correlate the clinical presentation with the CBC. And then if you're really suspecting leukemia, you do bone marrow aspiration. So what is bone marrow? Very basic, no? It is the tissue located within the cavities of the bone. When you eat bulalo or pochero, that's the soft part in between the bones. Okay, sometimes the parents, the late person will call it uyok. So these are the sites where we do the bone marrow. Okay, the most common site is the posterior iliac crest. Now, this is my favorite site and it is suitable for all age groups. Sometimes we use the anterior iliac crest if the patient is really obese, or in adults, no, they use this when the posterior iliac crest is inaccessible. Example, if the patient is on cast or has limitations in movement. Okay, have never done a sternal bone marrow aspiration, and I don't think I will ever do. And tibia, yes, I have done, but very, very rare, because we can only do this if the patient is less than 18 months old. Beyond that age, the bone marrow specimen that you can get from that area is not really that reliable. Okay, so as for the nurses, no, this is the site where we inject the needle. This is the front view, anterior view, and this is the posterior view. So this is the posterior iliac crest. This is the sternum, of course, and just to show you, no, this is the tibia of an adult patient. I just want to show you where we insert the needle. It's just like doing an intraosseous access, no, in emergency cases. But we only do this if the patient is less than 18 months old. That's a marrow specimen, that's bone marrow needle. And again, for the nurses, no, I just want to show you where the needle goes. It goes through the skin, and then some subcutaneous tissue and fat, and then through this cortex of the bone, and then into the medulla. So the needle should reach this part to be able to get a good specimen. For the medtechs, you know this, Nana. So after you aspirate the marrow, you make smears. So these are unstained marrow specimen. And sometimes, no, the attending physician will ask you, you check if there are spicules, no, and you don't know what are spicules. So these are spicules. They're more prominent when the slide is stained. This smear is made using the squash technique. This one was made using the thin smear technique. Now the spicules are found here. And for the squash technique, the spicules are found here. Okay. Again, medtechs, you have seen this. Also the physicians, but the nurses, which was my target audience in making this lecture, you may never be able to see this under the microscope, but this would classify under nice to know. This is how a bone marrow smear would look like, a normal bone marrow smear. See, it's so nice. So nursing care, when doing in bone marrow procedures, no? So your role as nurses is, your roles as nurses are to educate, to prepare the patient, but most of the explanation should come from the attending physician. So you are there you may reinforce, you may assure the parents or the patient that maayo na kay na siya nga mo bone marrow ay kahadlok, no? So at least hearing that not from the physician itself, at least they would be assured my child will be okay. Okay, and you can also assure them that we do this almost every day and there are no major complications. No? And then What are your other roles? You can support and assist the patient during procedure. You position the patient according to the preference of the physician. Okay, and post bone marrow aspiration, it is important to apply pressure on the site for 3 to 5 minutes. And then you make the patient comfortable. After the bone marrow, the patient can ambulate right away. But it would be good to tell them that you rest for a while, for a few minutes, because out of anxiety, perhaps they will be hyperventilating, they'll develop hypocalcemia, they will become dizzy. Okay, so you monitor for complications, and often the complications that you are going to monitor are the bleeding complications. Bleeding at the site is bleeding at the site. Then don't forget to label the specimen properly. Okay, so we'll go to the leukemias. First, my favorite, of course, the acute lymphocytic leukemia. This is my favorite because it's easy to treat, no? And you're giving a bad diagnosis when you disclose to the mother, to the parents. You're telling them that your patient has cancer, but you start first with the good news first. Like, mommy, the good news is we know what's causing the problem of your child. The bad news is it's leukemia, and then the good news is it's treatable. So you do the sandwich technique when you disclose. And so I like this because it's not all bad news. Unlike the other types of leukemia, when I really can't tell them any good news. Okay, so it's malignancy of the lymphoid stem cell. It can either be B or T cells, and it is the most common childhood malignancy. The incidence is highest at 3 to 7 years old, but it can also occur in adults. So the clinical manifestations, they are similar to all types of leukemia, except in ALL, you may have hepatosplenomegaly, which is not seen in AML. It's a different story when you're dealing with CML. And for boys, you may have testicular swelling. Of course, all the signs and symptoms are related to bone marrow suppression. So you have anemia, you have fever because of infection. So how do you make the diagnosis? You start with the CBC. Always start with the CBC. And the CBC will show you anemia with thrombocytopenia. The WBC could be normal, but with lymphocytic predominance. But sometimes the bone marrow, the WBC could be very high. But often it is normal. And this is what will make the parents suspect that the patient does not really have leukemia because the WBC is normal. Because oftentimes the lay person would think that before you can make a diagnosis of leukemia, the WBC has to be very high. They think na this is what they say that ang puti ni kaon sa pula, no? Which is very wrong. There's walay kinananay nga nahitabo. You tell the parents, walay kinananay nahitabo. No, the WBC seems the patient will have low red cell count, low hemoglobin because they are suppressed with the overproduction of abnormal WBC. But it is important that the WBC could be normal in these patients, but with lymphocytic predominance. But these are actually not lymphocytes, but actually lymphoblasts. Okay, but it is just that the Coulter counter machine that is used to do the CBC cannot detect lymphoblasts. That's why it is important that the medtech should do a manual differential count. Okay, so of course you do a bone marrow. The bone marrow in these patients will be hypercellular with more than 20% plus, and then you do a lumbar puncture. Okay, the lumbar puncture is done to detect CNS disease. Okay, so nice. No, this is the smear of a patient with ALL. Okay, again for nurses, nice to know, not must know. Okay, again, I will skip this one in the interest of time, but just to mention this one. We get so excited when we see ALL-L1 lymphoblast because it correlates with a good prognosis. Okay. So there's a new classification, WHO classification, which unfortunately we cannot do in our setting. Most often we cannot do cytogenetics, we cannot do immunophenotype, either because it's not available here or the patient can simply cannot afford the test. Naurot na lang ang kwarta sa pasyente, no, pakakastart ng treatment. So sometimes we skip with the other tests. We just base our diagnosis only on morphology. Okay, so how do you treat? No, I cannot overemphasize this enough. Chemotherapy. No, there's no other treatment for ALL. Chemo ra gyud siya. And there's no herbal medicine that can make the leukemia go away. No electric current therapy that can make the leukemia go away. No, and often the parents will ask me, Doc, I don't want to subject my child to chemo because that's poison. No, and my response to this one often is very blunt. I would tell them, without chemotherapy, without treatment, your child will die. But with chemotherapy, your child will have an 80 to 90% chance of being cured from leukemia. Okay, you in your part, the nurses, the interns can reinforce this because it is very difficult if all the information, the source of all information is just us, the attending. Maura gina siya, kaninahan siya magwarta. No? And the problem often is the grandparents. They're the ones who would tell, ipakimo guna nimo, mamatay na, magluya na siya. No? So sometimes here, the parent support group would come in. If they know other parents who had a child with leukemia who got cured, they will be encouraged to subject their child to chemotherapy. So what sort of chemotherapy? It depends on the risk stratification. So the low-risk patients are given less intensive regimens. The overall 5-year survival rate, 75 to 80%, but in some centers, they report as high as 90%, in children. Okay, but in adults, it's a different story. So these are the drugs that we use to give chemo, that are used in ALL. Okay, these are just the commonly used drugs in ALL. So the treatment is often divided into phases. It's not like in oncology where you have cycles, but in leukemia, they are divided into phases. So the induction phase is the initial phase. It usually lasts for 4 weeks. 90% of these patients will achieve complete remission. Some protocol will use only 3 drugs, others would use 4 drugs. And what is important in this phase is that it should not be interrupted. As much as possible, it should not be interrupted. That's why you may have noticed, especially the nurses, when they text us the CBC and it would show a low WBC count, we would still tell them to go ahead with the chemotherapy, because the purpose of this phase is to kill as many abnormal cells as quickly as possible. This CNS prophylaxis phase is actually not a specific phase. It is given throughout the entire treatment, throughout the entire chemotherapy treatment of the patient. The chemo is injected directly into the CNS through spinal taps, by doing a lumbar puncture. This is essential part of treatment for all ALL. Before, in the 60s and 70s, when you say the patient has leukemia, it used to be a death sentence. There's no cure. And later on, when they discovered prednisone, vincristine, the patients would go into long-term remission, but not really long-term if they don't do the lumbar puncture, if they don't give the intrathecal. So this is essential part of the treatment. So some parents would tell me, no, pwede ba doc? No more lumbar puncture, no more IT? Ay na lang. Might not as well give chemotherapy because eventually the patient would relapse. So it is painful, yes, a little painful, but tolerable. Okay, some protocols, some physicians would only give methotrexate. Me and most of us here in Cebu would prefer triple intrathecal. We prefer to use triple drugs: methotrexate, cytarabine, and hydrocortisone. The reason is because we cannot really stratify our patient which one would fall under low risk, high risk, or medium risk, or standard risk, because we don't have cytogenetics, we don't have flow cytometry. So we just give triple intrathecal chemotherapy. So the consolidation phase uses either, depending on the protocol, no, they use cytarabine or high-dose methotrexate. And the purpose of this phase is to destroy any cancer cells that survive the induction phase. Paniguro ni siya. The same with reinduction, reconsolidation, because some patients, they are slow responders. No, they don't really respond well to the initial induction phase. So to ensure cure, we give reinduction and reconsolidation. It uses the same drugs as induction. Okay, so panigurado gihapon ni. And in the maintenance phase, others call it continuation phase, we use mainly oral chemotherapy. Daily mercaptopurine and weekly methotrexate. And they're given for a period of 2 to 3 years. What is important here is that you tell the parents, no, we tell the parents not to be complacent during this phase, because in this phase, the patients would be running around, wala. The parents would tell me, wala siya boy, sakit do. So the grandparents would again tell them, uy, dangan na ng chemo kay okay naman yung patient. So what happens? They stop the chemotherapy, they relapse ang patient. So as nurses, you can reinforce education. Okay, so how do you give chemotherapy? IV, oral, IM, sub-Q, or IT. Okay, so this is not an exhaustive list of chemotherapy drugs, but I would just like to point out a few. No, for L-asparaginase, they may develop severe allergic anaphylactic reactions, especially when you give it IV. So that's why it is important to monitor the patient. Don't let them go right away after giving the drug. Okay, and doxorubicin, vincristine, etoposide are irritants, skin irritants. So you make sure that you have very good backflow before you give this drug. Methotrexate, it's safe to administer, but hydration is really important. So when the hydration line is out, especially for the residents here, for the clerks, you have to reinsert that IV right away, because it's very important to prevent the patients from having toxic adverse events from the methotrexate. Same with cyclophosphamide, hydration is very important. Cytarabine is generally safe to administer, especially with low doses. Okay, so must know for nurses. Okay, even also for residents, what to do. Okay, extravasation. Some chemotherapy drugs are very irritant when extravasated. Okay, so what do? You stop infusing right away, and if you can, you attempt to aspirate. You remove the needle and cannula, you apply cream, the flamazine cream, and then you cover with dry dressing. Then you complete the chemotherapy infusion at another site, and then you instruct the mothers to continue the flamazine cream for 5 days, 2 times a day for 5 days. And you can apply also cold compress or ice pack on the site. And then don't hide it from the attending. No? Inform the attending right away, inform your senior. No? 2 to 3 years ago, when there was a very high turnover of nurses, we get a lot of patients cancer patients with burns at the injection site. No, but nowadays, because they're very good, wala na nakalarga because of COVID, they're very good in cannulation already, in cannulating. Except they're very good in cannulating patients, but not attending. Okay. So, as usual, nope, I cannot again. Prevention is better than cure, so it's best avoided. Make sure there is good backflow before you inject the drug. Bahala na kadaghan matusukan. No? As long as you're sure that you're inside the vein, do not have more than 2 attempts at inserting a butterfly or cannula. Okay, call a friend. And this one, never use antecubital veins. But again, in the ideal setting, never. But sometimes out of desperation, we're forced to use that one. No, but you inform the parents, you inform the attending, no, and you make sure that you're inside the vein. Okay, and avoid the use of foot veins. If you're looking for veins at this site, again, in the ideal setting, consider central venous line or takat. Okay, but this is easier said than done. Okay, most of our patients cannot afford to have a central line. Okay, so lumbar or spinal tap. Just to show you where we insert the needle. No? It is a painful procedure but tolerable. If the patient do not need sedation, okay, it's best to apply EMLA at the site. No? An anesthetic, a local anesthetic cream. So where do you put it? So you feel for the hip bone. Top of the hip bone, you draw a line downwards, and then from the cleft of the buttocks, you draw a line upwards. Where the 2 lines intersect, that is where we inject the needle. So that is where we put the EMLA. No? It is best that you apply the EMLA cream 1 to 2 hours before the procedure. Don't wait for the attending to tell you to apply EMLA. No? If you know that the patient is for IT and you have a go ahead from the attending physician, apply the EMLA 1 to 2 hours before the procedure. That way, the cream will penetrate through the skin and the subcutaneous tissue. So when we inject the needle, it's really no pain, no? Painless siya. So this is where we inject the needle. We feel, that's why we do that. No, we feel for the spinous processes, and then we insert the needle here, and we inject the drug. First we aspirate fluid. No, we send it to the lab for cytology, and then we inject drugs. Okay. Wait, So after the procedure, you place the patient on Trendelenburg position, but this is very uncomfortable. So sometimes we just put the patient on supine with a pillow supporting the buttocks for 1 to 2 hours. Okay, this will ensure that the drug reaches the CNS, and it will also minimize spinal headache. And I think over time.
Go ahead. Yeah.
I still have time. How many minutes? I lost track of time. Okay.
Whatever you want, Ga.
I want to share this one. This is quite long, but I can summarize because I really want to share this with the nurses and to the residents. We have some ALL prognostic factors because as I have mentioned, no, it's not 100. The cure rate is not 100%. Okay, so what are the factors that will affect this? Not all those with ALL will get cured of ALL. So the best age to get ALL is between 1 to 10 years old. Less than 1 year old, that correlates with bad prognosis. But if it's more than 10 years old, also, it is also the patient must become high risk. Okay, so the best age to get ALL is between 1 to 10 years old. Sex. No, the male sex usually have poor prognosis. Before we used to give intensive chemotherapy, the male sex have poorer prognosis. And why is that? It's not because they are the weaker sex, it's because they have testicles. And the lymphoblast, they love to hide in the testicles. Okay, another prognostic factor is the WBC count, the initial WBC count. If the white cell count at diagnosis is very high, it's more than 50,000, that correlates with a bad prognosis. Of course, CNS disease at diagnosis is bad. Hemoglobin at diagnosis is surprisingly, the lower the hemoglobin, the better the prognosis because it correlates with early detection of the disease. Okay, these two we cannot do here, but it's worth mentioning that if you have, normally we have 46 chromosomes, and if you do cytogenetic analysis, if you do karyotyping, and if the patient, the lymphoblast of that patient has more than 55 copies of chromosome, it usually correlates with good prognosis. Immunocytogenetics, there are some cytogenetic features that correlates with good and bad prognosis. An example is the Philadelphia chromosome. It correlates with bad prognosis in patients with ALL. Okay, so an important prognostic factor is the prednisone response because with the patient, we classify the patient as good prednisone responder or bad prednisone responder. So when the patient is diagnosed with leukemia, ALL, we give prednisone. So if we say that the patient is responding well to the prednisone, if the if the lymphoblast count would fall below less than 1,000, after 7 days on prednisone treatment. Okay, and of course, treatment protocol. You may disregard all the other prognostic factors if you don't give adequate treatment. If you don't treat the patient, your patient will still die of leukemia. So you may have all those good prognostic factors, but if you don't treat, the same thing, mamatay. So the next, if we still have time, how many more minutes? Make 10? I don't have. I'll just run
It's okay,
through
Ga.
leukemia. The next type, the AML. This is a type that I really don't like because I don't have good news to tell the parents. They're very bad prognosis. And first, it's malignancy of the myeloid stem cell. Okay, the manifestation is similar to ALL, although you don't have hepatosplenomegaly in patients with AML as compared to ALL. How do you make the diagnosis? The same with ALL. Okay, again, the WHO classification, nice to know, but we can't do this also. And this is what we can do, but I don't want to go through that one. For the nurses, you don't need to know this, but it is worth mentioning that if you have FABM3, it's still AML, but among the AML, this has the best prognosis. So usually the pathologist would make sure, once the pathologist is sure that he's not dealing with ALL, the pathologist is sure that it is AML, the next thing that he needs to do is to make sure that he is not looking at APML, APL, or FABM3 AML, because the treatment for this type of AML is different from the other types. Okay, and another worth mentioning, this one, because I know that the nurses would complain, kadugay, ano niya maghimog, makabon maro, banga, gina siya nga doctor. You didn't know that the attending was having difficulty in aspirating the marrow because he or she was dealing with AML and 7. So in this type of leukemia, the characteristic feature of this one is that you will have very difficult marrow aspiration. All sites na imo natusukan, still dry. So don't blame the attending. It's a type of leukemia that's causing it. Again, very bad prognosis. Okay, nice to know also, just to show you, I want to show you this one because you will never get the opportunity to see this under the microscope. That's M1, M2 with some differentiation. This one, M3, my favorite. No? These are our rods. When you see this in a cell, in a blast cell, you would know that it's really myeloid and not lymphoid. And this one, AML M3, no, the prominent feature of the blast of this type of leukemia is that you have numerous our rods here. This one. And this is what you call fagot cells. Oh, I like the name, fagot cells. This is M4, M5, okay, M6, and this one M7. This is a culprit why you have difficulty in aspirating the marrow specimen of these patients with AML M7. Treatment, okay, chemotherapy also. For those with good prognosis, chemo only. But those with bad prognosis, chemo plus PMP. And the treatment is very intensive. Most of our patients may survive, may go into remission, but they die because of the complications, because of sepsis post-chemotherapy. This one is a grab photo from FB. I met this patient when he was 6 or 7 years old. He underwent bone marrow transplantation and now he's a teenager. I asked permission from the mom, by the way. Okay, who's this? First to guess, of course you know him, no? He's Francis Magalona. He died of AML. Another type of leukemia which I don't like, no, the juvenile myelomonocytic leukemia, very bad prognosis. Fortunately, it's very rare also. No, so God is so good. The good type, the ones that are curable, they're very common. But the rare ones they're incurable. So it's common in less than 2 years old. It is associated with some syndromes, and the WBC count is often more than 25,000, but there are blasts in the peripheral smear, but the bone marrow, you can see less than 25% blast cells. When you do cytogenetics, you may find monosome 7, and this is one of the part of the diagnostic criteria. You have increased hemoglobin F or H. Okay, so very bad prognosis. No, if you diagnose this type of leukemia, you prepare them for bone marrow transplantation right away because they respond poorly to chemotherapy. Okay, so this is the smear of a patient with JMML. And if you remember 4 or 5 years ago, this courageous Katie was very much in the news. I grabbed this from FB again because when the parents were told that their child Katie has JMML, and then they were told about the prognosis, the parents refused to give up. So they went to social media, and then they solicited money, and they were able to raise money enough for them to go to Singapore for bone marrow transplantation, and unfortunately, the patient died. The patient still succumbed to the disease. CML, you may not see these patients often in the onco unit, for the nurses, because the treatment is just oral chemotherapy. Okay, but sometimes you may see them at diagnosis, when they're having their bone marrow procedures. Okay, one thing important with this type of leukemia is that the characteristic feature is the Philadelphia chromosome, the 922 translocation. Okay, let's skip. Okay, Monisha, this is the typical leukemia wherein the layperson would often refer as gikaon iyahang pula sa puti because the WBC count of these patients are very high, sometimes more than 500,000. Okay. So this is just to show you the buffy coat of this patient. These are the white cells. This is normal, and this is the buffy coat of this patient, of a patient with infection. So So I've mentioned Philadelphia chromosome. So this is the normal human karyotype. In patients with CML, the chromosome, there's translocation of the 22 to the 9 chromosome. So you call it 9-22 translocation. So part of the 22 went to 9. So this is the actual chromosome. Those are, the previous slide was just a graphic presentation. Okay, so the treatment is oral, so you don't see them often in the Onco unit, except for bone marrow aspiration procedure or for transfusion if needed. Okay, so look at the smear. So nice. This is bone marrow smear of a patient with CML. Okay, so this is Karim Abdul Jabbar. He has CML also. And CLL is a type of leukemia that is never seen in children, and you don't get to see them also in the Onco unit because we don't, the adult hematologists don't need a bone marrow to diagnose this. Okay, so there's no cure. You just look at the peripheral smear of these patients, and they're all composed of lymphocytes, mature lymphocytes. They're not blasts, they're mature lymphocytes, and they don't also give chemotherapy to these patients. It is almost incurable. Okay, so thank you. I hope you were able to get something. Maski kadto na lang the common manifestation of ALL in children, and these are the patients with ALL. Most of them are survivors now. And pre-pandemic, they used to have done so many activities. And they're very helpful in helping these patients cope. Some of these patients are survivors, some are unfortunately, a few did not survive. Okay, so more activities. And lastly, with as important as the treatment, the medical side of treating these patients with ALL is the psychosocial support, the financial support that this foundation would give to these patients. Without this foundation, I don't think we will achieve a high cure rate for ALL. Okay, I think that's it. That's it,
Okay,
Pansi.
hello. Thank you,
Yes.
Dr. Dioko, for a very extensive and very comprehensive lecture.
Comprehensive. Well,
Comprehensive.
not that everything pagani.
I hope the nurses are finding out the usual things that they do at the clinics at the CCI. So I'm asking them to have their questions ready already.
Ay na lang. Ay na lang.
Para, so you will stay longer, Paga, kasi we will continue with the lecture on the second, that is the immunotherapy. This is also commonly done now in our Onco unit. And I'm sure the residents also have this in the wards when the patient came in with certain medications. So these are common nowadays, and the new immunotherapy that we do in medical oncology. So stand by that so that the open forum will be later. So after the lecture of Dr. Ellie May Villegas. Okay? So now we go with the basic principles and basic things we need to know about immunotherapy by Dr. Villegas.
So if Dr. Joko's lecture was very basic, mine could not be very basic because immunotherapy drugs by itself are very new. So I try to touch on what is immunotherapy, and really the bulk of this afternoon's talk for my part is to discuss on immune-related adverse events, and we call them IRAs because they are the side effects of immunotherapy. And there are 6 alterations in cell physiology that would dictate malignant growth. So why do cancers proliferate? It's really because of the hallmarks of cancer elucidated here. So there are 6. And number 1 is sustained proliferative signaling. So What it means, it's very self-sufficient in growth signals. Second, they can evade growth suppressors. So we have anti-growth factors, but they can evade those. They can also be proliferating continuously, so activate invasion and metastasis, as well as inducing angiogenesis. As you know, angiogenesis is formation of blood vessels, and these blood vessels would feed the cancer cells. So cancer cells have the inept ability to be angiogenic, and they can also have enabling replicative immortality. They are kind of immortal because they have a limitless replicative potential. And they can also evade apoptosis. So as you know, apoptosis is programmed cell death. So all must die. All of us must die, as well as our cells. But somehow some cancer cells evade dying. So that's why they metastasize, and we have progression of disease. So by and by, the hallmarks of cancer have been, have been profound already, that they've included 3 more. So from 6, it became 9. And the ones which were added were genome instability and mutation, tumor promoting inflammation, and this is the bulk of our lecture for tonight, for this afternoon, avoiding immune destruction. And there's also a thing called cancer immunity cycle. So you know about cell cycle in general. Everyone undergoes through a cycle, di ba? Pagkabata, and then we grow, and then we die. So, but for cancer immunity cycle, this is really several steps. This is a cyclic process that can be self-propagating, leading to accumulation of immune stimulatory factors that should amplify and broaden our T-cell responses. So it consists of 7. Let me just start by, the first step would be release of cancer antigens. So what are neoantigens? Because cancer is a genetic disease, for it to proliferate, it undergoes several mutations. It could be that a cell would acquire viruses or chemical factors, smoking, for example, and then it can acquire many mutations such that it cannot be cleared by the body. The more mutant the cancer cell is, the more diverse. It's not good because it's able to evade our immune system. So this release of neoantigens will then be presented to DC or dendritic cells here in step 2. So by there, they are captured by the dendritic cells. From 1 to 2, there are several signals which bring about this process now. There are several signals like pro-inflammatory cytokines and factors which are released from the dying cells. So those dying cells can be the source of these neoantigens, and also our normal gut microbiota, or our gut flora. And then step 3 would be to present, the dendritic cells will then present the captured neoantigens into MHC and MH2. So from basic physiology, all of us went through that in college, that they are the ones, there are peptides, they are the ones who present the peptides to T cells. And then after that is cycle number 4. Oh, by the way, this is the rate limiting step by which there should be a balance between T effector cells and our, where we am? I'm in number 3, no? Activated effector cells and the regulatory T cells. And then number 4, the activated effector T cells traffic and eventually invade the tumor bed. So as you can see, this is very small, but this is the tumor bed. This is the basement membrane. So the T cells would seep itself through that, so that the cancer cell would then uptake it. And then lastly, it would kill, target killing of cancer cells. So this is a cyclic process. Why is that important? Because our drugs now have, they anconize sila, so they have their own mechanisms of action. Like for example, the immunotherapeutic drugs we have now are immune checkpoint inhibitors, which are anti-PD-1 and PD-L1. So for anti-PD-L1 and PD-1, they act on the step at 7, killing cancer cells. Whereas the other kind of immune checkpoint inhibitor is anti-CLA4, or anti-cytotoxic T lymphocyte A4, like ipilimumab, so they act on number 3, which is the priming and activation of T cells. Although they are not immunotherapeutic drugs, our chemotherapeutic agents, our radiation therapy, our target cell would act on number 1 from the release of neoantigens from dying cells, and our growth factors like our GCSF and our vaccines would act on number 2 in cancer antigen presentation. You know of our targeted drug bevacizumab or Avastin. It is an anti-VEGF and it acts in number 5, which is infiltration of T cells into the tumor bed. Okay. So our immune checkpoint inhibitors right now in the market worldwide are 6. 5, most of these will target solid tumors, and 1 for Hodgkin's lymphoma, which is recurrent. The first immunotherapeutic drug which was approved in the market is ipilimumab. This one, it's an anti-CTLA-4. It was in 2011. It was first approved in melanoma. And there's also an anti-CTLA-4 tremelimumab. These are not yet available here in the Philippines, but our nurses might be familiar because for those of you who are also study coordinators, we have clinical trials using these drugs. So anti-PD-1, nivolumab and pembrolizumab, I think it was approved in 2014, followed by the newer PD-L1, which is atezolizumab, durvalumab, avelumab in 2016. So there's a myriad of solid tumors, not only melanoma, by which they can be used, like renal cell, urothelial tumor, head and neck, colorectal cancer, especially those with MSI high and DMMR. So our toxicities, the ones that we will be discussing now, are really the immune-related adverse events. You are very familiar already. Those who work in the Onco unit are very familiar with infusion reaction, and our targeted agents from monoclonal antibodies more or less do not differ from the infusion reaction we see from our immune checkpoint inhibitors. So I'm not so sure if I can stop sharing now, and we'll be sharing some video from YouTube. Let me try.
Hello and welcome to Dana-Farber Science Illustrated. Today we're going to be taking a closer look at how scientists use drug agents to help our immune system discover cancerous cells. Our bodies are made up of trillions of cells which work together to keep us healthy. One group of white blood cells, known as T cells, act as our own personal guides. They patrol our bodies relentlessly for signs of infection or other diseases and attack them aggressively. While on patrol, T cells use specialized protein receptors on their surface to latch on to cells and fully inspect them for signs that they may be cancerous. Once they've made a confirmation, T cells summon an attack on diseased cells. However, sometimes the T cells aren't able to recognize the bad cancer cells and they never attack. Scientists have found that many cancer cells carry proteins that act like masks and allow them to blend in with healthy cells. One protein in particular that cancer cells use for this deception is called PD-L1. When T cells use their PD-1 protein to latch onto cancer cells' PD-L1 protein, they're fooled into thinking that cancerous cells are actually healthy ones. They then leave the cancer cells alone and allow them to go on multiplying in the body. Scientists realized that if they could find a way to block PD-L1 on cancer cells, then the T cells could unleash an attack on them. This discovery led to the development of drugs made from natural human antibodies that block PD-1-PD-L1 protein interaction. The T cells are then able to recognize the cancer cells and begin their attack. Thank you for joining us on this brief look at the exciting field of immunotherapy. For more information, visit discovercarebelieve.org. And until next time, This has been Dana-Farber's Science Illustrated.
Okay, we're back. So I hope that was a good animation. I thought that was a very boring. I mean, basics of immunotherapy is really very boring, and I thought that there's no way to amplify your signal by showing that animation. So I hope you learn. Anyway, we go back. Immune checkpoint inhibitors, as you know, therefore T cell activation, increase inflammatory cytokines, and also binds to normal tissue. Now we go to the gist of this lecture, which is IRA, or immune-related adverse events. There are multiple mechanisms, as I've shown you, in the cell immunity cycle. And why do they come about? There's this diagram here that most of the side effects are really from head to toe. And why is that? Because there's this peculiar mechanism of action of immune checkpoint inhibitors consisting of blocking the inhibitor molecules, which are responsible for maintaining the immunologic homeostasis to avoid untoward recognition of cell molecules. So understandably, when the molecules are disengaged from their ligands, the consequence is disruption of the immunologic tolerance that can lead to indiscriminate unleashing of immune responses, causing several clinical manifestations. And these clinical manifestations would resemble autoimmune inflammatory conditions, which may involve almost all organs. That's why they're collectively called the IRAs. And I mentioned that there are several potential mechanisms, and I've just illustrated here about 4. So that was kind of discussed also a while ago. Any organ can be affected. They may be reversible if immunotherapy is stopped and treated promptly in 50 to 80% of the time. Those which are irreversible are endocrine disorders after hypophysitis, hypothyroidism, the severe ones. And if IRAs are left untreated, they will progress to more severe state. We do not know why other patients develop IRAs and why others do not. It is not also clear if it's only genetics, but there are some non-genetic factors, presumably. It's even also related, for some, they have bacteroides in their gut, a lot of bacteroides, and somehow bacteroides would shield them from having colitis as immune-related adverse event. We don't also know if we will use like probiotics or any other antibiotic to just prevent colitis in patients with immunotherapy. That is not yet proven to be preventive. If the IRAs are treated early, severity and duration decreases. This is an example of a clinical trial using ipilimumab. This was in ESMO. As you can see, the earliest IRAs would be dermatologic, like rash and pruritus. About before the 4th week, it appears, and then it dies down to the 10th week, and followed by your colitis, like GI symptoms, diarrhea, colitis, on the 5th week, and then it peaks and dies down on the 10th week, followed by, on the latter part, would be hypophysitis and your liver toxicity. So the average, these IRAs may occur at 6 to 12 weeks after start of treatment. However, they can occur within days of the first dose. They can even occur after several months of treatment, and even after discontinuation of your immune checkpoint inhibitor. We also don't know if the more IRAs that you have, is it better for the patient? That is still very controversial, but I will touch on that in a little while. This is a study with the use of ipilimumab and nivolumab. Again, nivolumab is an anti-PD-1 inhibitor. And ipilimumab is a anti-CTLA4. So the red is combination of EP and nivo. The blue one is single agent nivolumab. So as you can see, when you see dots there, it means it's the median time of occurrence. But the length of the line would also depict it would signify the range of when they occur, or the duration. So mostly, if you have a combination, it occurs earlier than when it is in single agent. What drugs? So we just classify this into CTLA4 inhibitor, PD1 inhibitor, and PDL1. CTLA4 inhibitors are commonly the more toxic ones. They are the ones which give you the eye rays as compared to your PD1 and your PDL1 inhibitor. This on the left side is distribution of grade 1 to 2 eye rays or immune-related adverse events, while that on the right is the severe eye rays or grade 3 to 5. Okay. So the question really is, is PD1 inhibitor a safer drug than PDL1? Not necessarily, because if you can see here, the p-value is 0.07. That's beyond 0.05. So that's not statistically significant. Okay, there's a question, lingering question in everybody's mind. This has not yet been answered fully, but is there longer survival for patients with a lot of eye rays? And this is a study on nivolumab, and this was published on JAMA Oncology. So as you can see, the lines are divergent, they are wide open. So meaning those patients who've had eye ray using nivolumab actually fared better. They had longer survival and overall survival as compared to those who did not. So I'm saying controversial because this is only one study, and there are studies of ipilimumab which confirm this. So at the minimum, why don't we just have a consensus that such events are not really required to obtain a benefit? There are those who did not have any eye ray and yet are responding very well to immune checkpoint inhibitor. So we almost forget the nurses can really help us, our onco staff can really help us in reminding also the doctors that aside from detailed questioning whether this patient has lupus or autoimmune disease or infectious disease, any endocrine diseases, we must also be able to get the history for bowel movement. So that's important because these patients might have a lot of GI toxic effects. And for blood tests, at the minimum, we must have CBC, our cardiometabolic panel, including your liver function test, your electrolytes, and sodium, potassium, your creatinine, that's included in the metabolic panel. And not to forget, if you are intending to use your immunotherapeutic drugs, please have your baseline thyroid function test and your glucose, like HbA1c. Why total CK? Well, not for everyone, but for those who are really prone to develop myositis and the like, it's better to also have your baseline creatine kinase and your infectious disease screen to include hepatitis and even HIV if you can, and lipid panel. I'm sorry. For dermatologic, you should have a full mucosal exam, not only on the skin, but all lesions present should be noted. And pulmonary function test, everybody now has pulse oximeter, so why don't you take baseline O2 at room air and on ambulation, or cardiac tests. So although these are safe drugs, but please have your cardiac function tests, especially your ECG and even your 2D echo. And some additional tests like endocrine tests, cortisol, ACTH. Why? Because these patients might develop AI or adrenal insufficiency and even hypophysitis, and pulmonary function tests and cardiac tests. All right. As I've mentioned earlier, because these immune-related adverse effects can affect any organ or any mucosa, the most common of which are dermatologic. I should bring this down. Dermatologic. So for those with melanoma, it's surprising to see vitiligo, but really it's common for your patients with melanoma and you're being treated with immune checkpoint inhibitor. Rash is the most common, pruritus, and I'll be talking about the rash later on. They can also have pneumonia, pneumonitis, hepatitis, myocarditis, and even your colitis, like your GI adverse effects and your musculoskeletal adverse effects. So why don't we start with the endocrine immune-related adverse effects? The most common would be your thyroid dysfunction and your hypophysitis. Okay. Those are the most common endocrine eye rays. And in this graph, it kind of summarized use of different immune checkpoint inhibitors. But as you can see, that when you combine your ipilimumab, which is anti-CLA4, and your anti-PD1 like nivolumab, there's a higher incidence of your endocrine IRAs. This will be a repetitive lecture now for every IRA that I'll be discussing. This is kind of the protocol that we'll be using for a minimal IRA grade 1 or minimal side effect. You just continue the immune checkpoint inhibitor and you do your weekly lab monitoring. For example, it's hypothyroidism, so you do weekly monitoring of your thyroid function test. If it's moderate or grade 2, you can hold temporarily your immune checkpoint inhibitor and use glucocorticoid like prednisone at a low dose of 0.5 to 1 milligram per kilogram or its equivalents. And if it's severe or grade 3, you discontinue immune checkpoint inhibitor temporarily, and you can up your steroid a bit at 1 to 2 milligrams per kilogram from 0.5 to 1 milligram per kilogram per day. But if it's very severe, grade 4, you should discontinue it permanently. You up your steroid dose, methylprednisolone, for example, at 2 milligrams per kilogram per day or its equivalents. For example, that's first-line treatment. What happens if they do not abate, the symptoms do not abate, the signs and symptoms? So you consider your second-line treatment, like addition of your anti-inflammatory drugs like azathioprine or your mycophenolate mofetil. If still it doesn't work, then probably it's time to use another agent like anti-thymocyte globulin or tacrolimus. So far, so good. I've had a handful of patients with immune checkpoint inhibitors, and luckily, with just steroids, these IRAs abate. Word of caution, if your patient has, for example, hepatoma and hepatitis, as an IRA is very common, please do not use your immunosuppressant infliximab because that will only worsen your liver disease. So endocrine toxicity, thyroid gland disorders are common. You should monitor your TSH and FT4 at least. Onset is low. And what are the signs and symptoms? You know this. IRA hypothyroidism does not differ from your hypothyroidism from thyroiditis. So patients have weakness, asthenia, constipation. They're very dry. They have hair loss. They have weight gain. They're more common with combination of your immune checkpoint inhibitor. So what to do? You repeat this requires TSH and FT4 monitoring every 4 to So the difference is you don't give your steroids immediately. Of course, if there's hypothyroidism and that's about TSH more than 10 persistently, then you give your thyroid hormone supplementation with levothyroxine. You can start slow and low, especially if the patient has a cardiac disease, and if it's severe, you have to hold it. And if the opposite would ensue, like your hyperthyroidism, thyroiditis is actually the most common cause of thyrotoxicosis, and sometimes patients would reclamo that they have painful neck. They have weight loss, palpitations, heat intolerance, tremors, anxiety, diarrhea, just like your patients with Graves' disease and your thyrotoxicosis. And on your biochemical monitoring, you see that there's high 43 and a low or normal TSH. And what is also different in this, because you have tachycardia, you have to give a beta blocker. If there's tachycardia, hydrate patients. And steroids are also not required for. So your endocrine disorders, hypo and hyperthyroidism, hold off on the prednisone first so you correct on the thyroid hormone abnormality. What if it's hypophysitis? It is very common for your anti-CLA4. Again, what is in the market is ipilimumab and your tremelimumab. None yet in the Philippines, but that's coming because we have a lot of clinical trials using these drugs. They are rare with our PD1 inhibitors and our PD-L1. So patients would reclamo that they have headache, visual disturbance, so they require immediate attention. When you do an MR, you find that the pituitary gland is kind of enlarged. And when you do your biochemical monitoring, there's a low ACTH with a low cortisol, low TSH, or low everything. ACTH, cortisol, TSH, and FT4. So you have to be wary of hydrating these patients very well. And also, before you give your levothyroxine or your thyroid hormone replacement, please, unahon, you give your cortisol first because you don't want them to be in adrenal crisis. So that requires all of these things. You have to monitor them. So same, because this is similar to hypothyroidism, you have to give your thyroid hormone replacement. No? Testosterone or estrogen treatment as needed in those without contraindications, and always start steroids before thyroid hormone to avoid precipitating adrenal crisis. And if it's grade 2 or moderate symptoms, you consider holding off on your drug and you give still your hormone supplementation, and then you withhold if it's more than grade 3 or 4. What if the patient has primary adrenal insufficiency? So you find these patients very weak, hypo, not hyper K. So why don't you get your cortisol, low morning cortisol and ACTH? You have a high morning ACTH. So these patients are also volume depleted, they're hypotensive. So to diagnose. So you see that patients are very fatigued, they're skinny, they have weight loss, and how to manage, still the same as my algorithm before I started all of these. So you have to give your steroids low dose first, and then you can up the dose. But when you give your steroids, you have also to taper them slowly because you don't want them to develop AI or adrenal insufficiency. They can develop type 1 diabetes, though this is more common with your PD and PD-L1 inhibitors. The same symptoms as with any other diabetes. They go to the toilet very often, ihi ng ihi, thirsty, they're very thin, tired. And aside from treating them, of course, for your blood sugar, so you treat them as any other, but you have to be wary of monitoring, especially your urine ketones. Let us go to non-endocrine, and skin toxicity is very, very common, especially rash and pruritus. They're reversible, well manageable, and there can also be bullous dermatosis aside from the ordinary rash. But severe cutaneous reactions can also happen, like your TEN, toxic epidermal necrolysis. As I've mentioned earlier, if you have a melanoma patient treated with ipilimumab, for example, or nivolumab, it's not uncommon to find vitiligo, and I will show you what vitiligo looks like if you don't know yet. How do you compute for BSA for those with skin lesions? So the rule of 9. So you divide your whole body into 9. So one leg is 9%, the other leg is 9%. But when it's in the trunk, you double it. So 9 plus 9 becomes 18. And when it's in the face, 9 divided by 2, that's 4.5. And also 4.5 for your right upper extremity and left upper extremity. This is a picture of your pruritic maculopapular rash. So that is not only for immune checkpoint inhibitor. Our staff would know that even if we give our monoclonal antibodies like our anti-EGFR or our tyrosine kinase inhibitors, you'd find them to have some similar rash. Although those tyrosine kinase inhibitors have acne-like rashes. Vitiligo, so whitening of everything. This is bullous rashes. Okay, so that might be very small, but bear in mind that aside from really hydrating on using emollients and your moisturizers, still your best friend for eye steroids. So mostly you use your topical steroid cream. If pruritus is a prominent symptom, you use anti-allergies or antipruritics. But if it's grade 3 or 4 or severe, you use oral corticosteroids aside from your topical, and then you stop your immune checkpoint inhibitors. Of course, if it's SJ already, you have to hospitalize patient. Any rash that does not promptly resolve with topical steroid cream or with showing signs of blistering should be evaluated promptly by a dermatologist or the expert, and biopsy should be considered. Colitis and hepatitis are the more common GI toxicities, and they are well described for anti-CLA4. What's the anti-CLA4? It's ipilimumab and tremelimumab, and less for your PD and PD-L1 inhibitors. So diarrhea is common in 27 to 54%. NSAID use was associated with increased risk, so be wary. Colon perforation can happen in 1 to 1.5% of melanoma with EP. So always examine your patients, and it occurs earlier with your anti-CLA4. When they are scoped, so you see all these manifestations. So how do you know that it's possibly colitis? Patient diarrhea, abdominal pain, rectal bleeding, mucus in the stool, and fever. So when they are being treated with your immune checkpoint inhibitor, please refer to your gastro ASAP and may treat accordingly. Just with the steroids, if aside from controlling the diarrhea, so if it's grade 1, less than 4 stools, please hydrate them very well. Just hold off the drug, and if it's 2 to 6 stools, you may use your low-dose steroid. Endoscopy should be highly recommended for cases grade 2 because they might be needing infliximab. And that is an immune suppressant. Grade 3, that is more than 7 stools per day, you consider permanently discontinue the drug and hydrate the patient, give a higher dose of steroid, and discontinue if it's grade 4. Hepatitis, the same. So these are the parameters. Always get your liver function test before you start your treatment and before your treatment. Pneumonitis is potentially serious, so let's spend a few minutes on this. The X-ray or the CT scan would not look different if you are using IRE or if this were pneumonitis from, for example, your tyrosine kinase inhibitor, the oral ones. Overall incidence is 5%. 3% is because of the use of PD-1 and PD-L1. 10% is from combination, including anti-CLA4 or PD-1 and PD-L1. The median time that it occurs may be from 9 to 19, but the median is 2.8. Earlier for those in using combination of immune checkpoint inhibitor. The same treatment, so you go clinical and by grading. Low-dose steroid for grade 1, grade 2, and grade 3 you up your steroid, and if it doesn't work, you can use your second line or your third line agents. Musculoskeletal. It is not common, but I've had patients who are really, they cannot, after 2 weeks of using your immune checkpoint inhibitor, they cannot even feed themselves because they cannot, move up their upper extremities. So they can be joint pains like arthritis, improvement of symptoms with NSAIDs but not with opioids or other pain medications. So this is suggestive of inflammatory arthritis. So you get your autoimmune markers. Myositis is also seen by an elevation of your CK, but muscle pain can be severe, so they can be life-threatening if the respiratory muscles or the myocardial muscles are already involved. Sometimes they can be polymyalgia-like, so there is marked pain and stiffness in your upper and lower extremities with no signs of true muscle infiltration, no CK elevation, and when you do your EMG, it's really kind of normal. So median time when it occurs around 5.4 weeks. There can be renal toxicities like nephritis and nervous system toxicities. MG or myasthenia gravis, GBS. Sometimes you use your immune checkpoint inhibitor and you don't know why. These patients have a demyelinating-like syndrome. So it could be an IRA. That's why you have to use your steroids for this promptly. Okay, I'm very fast because this is very academic. And anyway, the treatment is kind of the same. So, rarer IRAs may happen. Hematologically, you have your hemolytic anemia or even your thrombocytopenia, hemophilia. Cardiovascular toxicity may happen rarely, less than 0.1%, like myocarditis, pericarditis, arrhythmia. So, ocular toxicity like your uveitis, episcleritis, and nephritis. Suffice it to say that immune checkpoint inhibitors are very safe. However, in the small percentage of patients, IRAs can occur from mild to severe. So, instead of looking for other reasons, when the patient is on immunotherapy like immune checkpoint inhibitor, always think that it might be because of that, and prompt treatment has to be given. So, does immune suppression have unintended effects? Immune suppression is the use of steroids. So, steroids, when you treat your IRAs, The steroids have unintended effects. So this is very busy, but you all know that what prolonged steroids can do, diba? They can cause your avascular necrosis of your joints and also your diabetes, and opportunistic infections can occur. So also taper steroids slowly, not abruptly. So take-home message, what is important is for the patient, our staff at the onco unit, like our nurses, our pharmacists, and family caregivers should receive timely and up-to-date education about immunotherapies, their mechanism of action, and the clinical profile of possible IRAs prior to initiating treatment and throughout the treatment and survivorship. There should be a high level of suspicion that new symptoms are treatment related, and in general, your immune checkpoint inhibitor therapy should be continued with close monitoring for GI toxicities, with the exception of neurologic, hematologic, and cardiac toxicities, of course. You hold your immune checkpoint inhibitor for most moderate or more, or grade 2 or more toxicities, resuming when symptoms and or lab values revert to grade 1 or less. So actually, you can still use your immune checkpoint inhibitor if you're able to reverse all the symptoms. Steroids, the low dose is 0.5 to 1 milligram per kilo per day of prednisone for your mild or grade 1. For your grade 2 or 3, you up your steroid to 1 to 2 or even 2 and higher milligram per kilo per day. Steroids should be tapered over at least 4 to 6 weeks, and if they do not improve with 48 to 72 hours of high-dose corticosteroid, you may use your infliximab treatment. When symptoms and or lab values revert to grade 1 or less, you may re-challenge with your usual immune checkpoint inhibitor, the one that you used prior, but caution should be advised, especially for those patients with early onset IRAs. It's not all the time that when they develop IRAs, you stop the treatment temporarily, that when you reintroduce it, they will still develop IRAs. No, it's not all the time. So still you can use the same drug. Those adjustments are not those adjustment of the immune checkpoint inhibitor, like for example your pembrolizumab, you use it for 200 milligrams. For melanoma, it's 100 milligrams. You do not dose adjust it. So example also for your atezolizumab for hepatoma, when it's 1,200 milligrams, you do not dose adjust it. You just use your drugs to treat your IRA. In general, most severe or grade 4 toxicity require permanent discontinuation of your immune checkpoint inhibitor, with the exception of endocrinopathies that have been controlled by hormone replacement. So Monday morning, because today is a Saturday, and on Monday, we hope that you have learned something from today, especially from Dr. Suga's very fine lecture on leukemia. So Monday morning, when they are treated with immunotherapy, and then you find that your patient has diarrhea or colitis, you treat promptly. No, if they have skin rash, pneumonitis, elevation of your LFTs, your bilirubin, and endocrine symptoms, they might be really immune-related adverse effects. And thank you very much for listening.
Good. Thank you, Dr. Villegas, Imik, no, for a very extensive and comprehensive lecture. Sometimes she forgets na it's not the medical oncologist already. Hello. Palakpakan ko, no? Nick? Hello. Morning.
Yes, no.
Yeah, you can hear me. I transfer to the other side because otherwise you will have echoes, no? So, anyway, now the floor is open for the question and answer. Okay. May we ask Dr. Villegas to be back on screen?
I'm not yet back.
Hello.
I'm back.
Yeah. Okay. Suga, morning. Okay. Any questions from the nurses, since this is mostly for the nurses and the residents? No? So hopefully we have. Actually, I asked some questions from the nurses here. Nami si karon sa SEDA. No. What is of the current advancement? No. Forms for the treatment of leukemia? This is a question from the nurses.
So,
What is the most current advancement or the new treatment for leukemia nowadays? Is there any
Depends
other
on
than the
the
chemo?
leukemia.
Yes.
Still, it's chemotherapy. Just chemotherapy. And they have these CAR T cells, but we cannot do that here. Yeah.
We're not doing it here in Cebu, but
Yeah.
they're doing it in Manila.
It's very interesting, actually, but not here, not applicable. It's very new. But
Okay.
still chemotherapy. It's the mainstay of treatment for ALL chemotherapy again. Especially 80 to 90% in cure rate, even with
Another question is, what is the most youngest among your patients? Sorry. Mawala ka ga. Sorry. We did not catch the few sentence after ga. I think it's the internet connection. Nihina yan internet. We cannot get your answer ga. I think it's the internet. So we're losing Dr. Dioko. Probably a question. Okay, Ga, are you back?
Suga is in Masbate now. She's
Okay.
doing public service.
So both public service in both Masbate and Cebu. Now you're doing both.
Can you hear me na?
Yeah,
I
kanina.
use my headset.
Yeah. You can probably turn off your video if you want para better ang imuhang. Or well, we know na how beautiful you are naman.
No, brown out siya. So I shifted to data.
Uy, ga brown out there.
Can you hear me? May gapon.
Yes, Ga. Go ahead, Ga. Yes.
Ano na?
Yes.
Okay, anyway, and sa the youngest. No, my youngest was around 10 months, but I've heard of what do you mean the youngest survivor?
Yeah. The youngest you have been treated ba in terms of leukemia? There's a question. What is the youngest patient that you treat on leukemia with chemotherapy, and how did this patient tolerate the chemo?
The youngest, so far that ako 10 months, but I've heard of a patient na less than mga 2 months old. Not my patient, but he's a survivor. Na 2 months old, and we thought really that the patient will not survive. Infantile leukemia is a very bad prognosis, but that would mean that we should not lose hope, no? Maski even we know that theoretically, bati siya prognosis, but we should not lose hope. We still give a bit of good news to the parents. Anyway, but the youngest, yes, that was the youngest that survived, not my patient, 2 months old, but my youngest did not survive, 10 months old at diagnosis. But I've seen,
Here.
yeah, saman.
Yes, you have seen one. Sorry.
I've seen one at a newborn with leukemia. We call it the MD that did not survive also. Anyway, let's not talk about bad news. Sige.
Okay, let's talk about the ALL, which is the good news. Your favorite among, and it's God is good. You say that
God is so
ALL
good.
is
Yeah.
AL is the more common
I lost
one.
you.
Yes. You hear me? Sorry. Kini, pasig nawala ka. Hello.
Hello, nawala na sa ko. So,
Okay lang ka, Ga. We can hear you loud and clear.
But I lost
We can
Arno.
hear you.
Okay.
Okay. Sa ALL ga,
Yeah.
you said, yeah, you can hear me. Okay, there's a question na since ALL is the most common, and you say they usually go into chemotherapy, no, and then from the induction, then consolidation, and then maintenance, and the long-term treatment of these patients. What is have you seen patients who have long-term effect like secondary malignancy
So far, wala pa.
Wala.
None yet.
Okay.
None yet so far. But yes, these minor effects of, in first world countries, they don't do radiation anymore. But here, if the patient would fall under the high risk, I would still give radiation because we cannot intensify that chemotherapy. We are limited to some doses only. So, yeah, so far wala. No? Kana lang, short stature because
That's
of
good.
radiation. But I'm still young. No?
We're
So,
still young.
Yeah, the oldest patient that I have survived is around 27 years old now. No? Still unmarried, but I have two female patients who had kids already. One is even pregnant now with a second child.
You're still young.
I'm still young, so I'm not ito na ninyo ang akong mga patients with secondary malignancies. We shy, especially with ALL, we shy away from etoposide with ALL, with the good risk ALL. That's why we don't see much secondary malignancy.
That's good to know, Ga. Now, there's a question also from the nurses. Again, for you, Ga. What is your opinion regarding
Tingnan na
the
sila,
stem
ha?
cell? Murag ganahan kay sila question nimo. What is your opinion regarding stem cell transplantation in treatment of leukemia?
With ALL, we don't do that except for the high risk, no, with the relapse ALL, but we can't do it here. With CML, bad kihapon. Bad. When they go into bone stem cell transplantation, that is essentially bone marrow transplantation na. You try to get stem cell and then you infuse it. No, but I have no experience about that, and based on the reports, not so good also. It depends really on the type of ALL also, because if you do transplant na, that means that's a bad type of leukemia.
Thank you. Okay. For Dr. Ellie May Villegas, now you know that you can still put your question in the chat box. Don't be afraid or ashamed. Okay. Before we go with Dr. Siguro kay Imik Villegas, no? Now we know that immunotherapy is like the new kids in the block, which is actually being promoted eventually. What is the relationship of the technology? How would the nurses detect those immune related adverse events from the immune checkpoints? And then what is your advice to them when they see them being treated with ipilimumab? Say first cycle, second cycle, what would they do on those cycles before giving? Nakamute ka. Kamute ka.
Because our onco staff are also close to our patients, and sometimes our patients would text them that they feel tired, unusually tired, and patients are not on cytotoxic drugs like our immune checkpoint inhibitors. So always a consideration that this might be an immune-related adverse effect. So they should be prompt referral to the attending physician so that laboratory monitoring can be done. And because one of the more common side effects is also thyroid dysfunction and even our myalgia, so that they can be managed, and we can also institute our steroids judiciously. So that's their role also. They can be a liaison, that assurance also to the patient that this is most likely reversible. Most of the time it's reversible, and most of the time it's mild. So dili lang nang ingon nga, ay syempre nago kay cancer, kapoy gyud ka. No. Always, if they are on treatment, it could be treatment related as well.
How would it be alarming for them? Like, for example, myalgia, you said sometimes there can be also certain fatigue because of probably hypothyroidism. What would you advise to the nurses that they would probably be alarmed of?
Yeah.
No.
For myalgia, if it's already like demyelinating syndrome, when they cannot even lift, when they cannot even feed themselves, when it affects activities of daily living, please bear in mind that that's already at the minimum moderate or grade 2 signs and symptoms, and it should not be disregarded. It should be treated. It should be managed when it affects activity of daily living, and it should be, yeah,
True.
the proper medicine should be given.
They say the recent vaccine now, which is the messenger RNA, which is the technology being used for COVID-19, stems from what we have in terms of the cancer treatment. Is this the same technology they use now in immunotherapy?
That I do not know. I'm not so sure. But what I know though is for our patients who are undergoing chemotherapy, they may have their COVID vaccines already, as long as we do not time it the time that we are having our chemotherapy. So you give it in between. For example, the interval is every 21 days, so you give it probably between 10 to 15th day. But for our patients on immunotherapy, our society has been kind of worry patients on immunotherapy, so immunotherapeutic drugs, and even for our monoclonal antibody like rituximab, to just wait for the completion of all the cycles before we do, because we know so little yet of the interaction between the COVID vaccine and our immune checkpoint inhibitor and our monoclonal antibody.
Does the COVID-19 pandemic affect your decision to give immunotherapy now?
Not at all. Not at all. We're even, if economics, setting aside economics, of course, I don't want to use the word wonder drug, but it's becoming a wonder drug mainly because, like for example, pembrolizumab, it's in a wide array of solid tumors, and even for recurrent Hodgkin's lymphoma, it may be used. So as long as it's indicated, so it should be offered.
There's a question here from Mark, Cabanyal. As mentioned during the induction phase, if the patient presenting leukopenia or anemia, the chemotherapy must be given. These only apply to the induction phase. Of the rest of the phases, is this only applied to the induction phase or the rest of the phases of chemotherapy? This is for Yuga. Or need correct any abnormalities in the CBC of the patient prior to giving the chemo?
So in different phases have different requirements for WBC, but in the induction phase, we tend to be very aggressive because we want to kill the leukemic cells as soon as possible. No, but in the other phases, we have certain requirements. Like that is applicable in the induction phase, but in maintenance phase, we have low requirements also for the WBC. No, in the consolidation phase, we have certain requirements.
So it differs from phase
to phase. But if you have noticed, maski mubro na kay WBC is less than 1 na in the induction phase, I would still say go. No, but we don't give IT if the platelet count is very low. So ma-worried man gud sila. I would get restless mode. Doc, mubo ang WBC. You said go. Yes, because the patient is still in induction phase.
So there are different requirements and there are different.
But after the patient is in remission during the reinduction sa CNS sa reinduction phase na, we can afford to delay the chemotherapy. Sometimes we don't give na, if it's very low, I would tell the nurse if rest na sala siya, defer the chemo. No? Yep.
Thank you.
You have different requirements.
Thank you. Now, there's a question from Dr. Lucero here. For both of you, I believe. Hello, everyone. Any update on the use of immunotherapy in pediatric acute leukemia?
Imi can answer that one because I have not used immunotherapy in my patients. Only in B-cell lymphoma. Before during my training years, but when I came back to the Philippines, training na lang.
No data yet on the use of PD1, PDL1 or even anti-CLA4 immune checkpoint inhibitor for pediatric tumors and pediatric hematologic tumors.
So, can you tell us, Mick, what are the indications in the adult so far, more or less?
Okay, for our more common immune checkpoint inhibitor like the anti-PD-1, which is pembrolizumab. Nivolumab is the other one, but it's not available yet here in the Philippines. So melanoma, that's also the first indication. And for pembrolizumab, almost all, from head and neck, squamous cell head and neck, to lung, to breast, triple negative, and even for endometrial cancer, for colon cancer, for advanced diseases, and your recurrent Hodgkin's lymphoma, urothelial tumors also, and melanoma, renal cell also.
There are increasing indication now for this.
Correct. And for your atezolizumab, which is your anti-PD-L1 in combination with your bevacizumab, you can use that for hepatoma.
So,
And lung and yeah, the tumors that I've mentioned.
Thank you. Now, there is a question here from the nurses. What is the difference of the basic BMA studies compared to the sent-out BMA aspirates?
Basic BMA studies would just need a pathologist to review it under the microscope. And then I think ang nangutana ni from Perpetual, because we usually send out because we don't have cytogenetics, we don't have flow cytometry, so we send that out. Like, for example, in the doing bone marrow in patients with CML, we need the Philadelphia chromosome. We don't have that in PSH. So we send that out. So that's the difference. Kung basic lang, any pathologist can do that one. That's what we do with the ALL. That's the only thing that we can do, especially for those patients with financial constraints. Okay.
How do you consider the doxo cumulative dose in pediatric patients?
As you have different protocols, different attending physician also have different protocols. It is ideally we do echo to the echo before we give the second phase of doxorubicin. But the dose in ALL of doxorubicin is very small. It doesn't reach 300 milligrams per surface area. So the cardiotoxicity for that dose is very low. So I don't usually do to the echo anymore before giving the second dose. We tend to Philippinize our treatment actually. Ideally, we should do echo and then we compute. But if you notice, we just give 30 milligrams for 4 weeks of dox in the induction, then 30 milligrams in the induction. If you compute that one, it doesn't reach even up to 200. So that's very safe.
You remember there is a lifetime cumulative dose of doxo. In our adults, we have to consider that. We don't. I don't. Yes. Okay. Can you hear me ba? There is a comment here. Madunggan ba ko? Madunggan ba ko?
Loud and clear.
Ikaw, madungog ka na, but a comment outside.
I don't know.
Ano man, who are with you?
Wala, na ako sa gawas manggod. Nara ko diri sa hallway kay para dili mi mag-echo ni i-mix sa ka lugar na nako sa.
Lamin yung food, no? Lamin yung food.
Dili ka. Sakto ba? Any questions from the audience also? And a question there is a question here. How do you deal with when you disclose leukemia to both the patient and the family? And then which one you disclose first, the parents or the child?
It depends on the age. Good age appropriate na siya nga disclosure. But again, this is because I like ALL, but this is a very lengthy topic. Kanang disclosure. No, for a teenager, I would talk to the parents first. But for the mga less than 4 years old, they don't understand. Pwede na sila dungan, but I would still prefer to talk to the parents without the patient. Kaya muhilak man ang parents. The child would feel the anxiety of the parents. So sila said, ma-anxious na sila, manunilak mo na akong mom. No? Yeah, but it's, that's one of the aspect of ALL that I really like, no? The psychosocial aspect. I will change career na, mag-psychologist ako, no?
Okay. True. It's one of I can imagine, no, the difference in disclosure to your specialty than to mine. If I have problem doing the disclosure, I cannot imagine disclosing it to the parent and also the teenager.
Yes.
You have to.
So I use the sandwich technique nga. I use the sandwich technique. Good, bad, good. So you don't leave them with bad news. No?
Yeah.
There's a question in the chat box. Now, this is a very common question. Dietary restrictions, none.
I would like to ask if the dietary restriction among children who are undergoing chemotherapy.
I'm very liberal, Manggod. Some would restrict. Like they would tell the mother not to give chips, not to give junk food. But I'm very liberal. As long as they're clean, they don't consume 1 liter of Coke, pwede na sila mag-Coke. They can eat anything as long as it is clean. No?
Okay.
Wala na shoot. Anything.
Okay. Kasi imo Mick, dietary restriction for adults.
Come on, do you have dietary restrictions?
I usually tell my patients as long as is it healthy food, no? Sometimes
as long as it's healthy.
Yeah, we need also the protein. Sometimes they don't want to have the meat anymore, and then they become cachectic and protein deficient.
Yes. Yeah, like my mom, di na gid mag-pork since na-diagnosed siya with colon cancer. You're old already. There's no dietary restrictions. Good.
True. Another one is there a chance that a mother who is leukemia survivors can pass down the disease?
5%.
5%. Okay.
Very, very nil actually.
As mentioned, that's another question. Ano pa bang question diri na wala ko nabasa? Okay. Not much. Okay.
Kung ano lang, PM na lang if you don't. Yeah. We don't have time anymore. It's already 4:17.
Oh, okay. Actually, both of you dalang-dala sa very comprehensive lectures, even to the immunotherapy. Again, some in the immunotherapy, it's mostly technical that we do, and then sometimes we do play, and then in terms of the management, I think it's more on the doctors. That's why they do not have much question. Well, okay, just the few words or the closing words or take-home message from both of you. We'll start again with Dr. Ellie May Villegas, then Suga.
Although immune checkpoint inhibitors are very relatively new in the market, but there will be increasing use in the next few months or days. So we have to realize that although immunotherapeutic drugs are very safe, immune-related adverse events still can occur, and it can affect quality of life if not cause the death of the patient. So they can be managed well, they are reversible, and we can still use our immunotherapy again if they resolve. So we have to examine our patients well and use our diagnostics also judiciously.
Thank you again, and then take-home message from our pediatric hematologist, another beautiful lady.
If there's one thing that I want you to remember, ALL is curable. So you help me spread that news. ALL is curable. And there's no other treatment except chemo. Dili pwede mag-herbal, ha? No electrocution. Sana yung electric current therapy for ALL daw. No, sayang. No, these patients could have survived. Sayangan ko. And it's not that expensive. No? Okay.
So, not all leukemia are bad. And not all leukemia.
Majority childhood leukemia, curable.
Yes, it's curable.
Curable siya.
Okay. That's what she wanted to emphasize to the residents, PGIs, interns. Not all leukemia are bad, and majority are actually curable.
It's curable.
Okay, now we go to. Thank you for in the interest of time. Okay, Mickey, probably and then we'll ask our another oncologist who is now in Dalaget. Dalaget ba si Jamela? To have her closing. Ay, nasa Bukid eh. From Masbate, Cebu, and now from the Bukid. We call another beautiful oncologist from our Cancer Institute to have her closing remarks. Dr. Jamela Sanchez. Okay, thank you.
Good afternoon, everyone. May hapon. Sorry ha, is it okay if I won't turn on my video? Okay, where I am now, wala bitaw ko'y pagwapa. So, I look like somebody nagikan ng laba. So,
Open your video, uy, I can see me da.
hindi, ayaw lang mi kay. Mura lagi ko gikan ng laba. Magkuan lang ko.
Maganda ba po yung mga picture diri, oh?
Ang kana na tanawa, yan nila ang
I
tinuod.
just flash on. Gipadaan
Oh, kaya lang, kailangan ko, bitaw, first and foremost, in behalf of PSH and the SPC sisters and everyone in our institution, thank you. And then I would like to express our appreciation to the speakers, my two beautiful friends, Dr. Villegas and Dr. Dioko, for their dedication in promoting continuing medical education, not just for the trainees, but also for us and the nurses. Thank you, our dear speakers, for the comprehensive talks on the basics of leukemia and immunotherapy. I learned a lot. I listened, I really listened. And to our most handsome moderator, one of the best trainers there is, and I speak from the heart. I always speak from the heart. Thank you, Dr. Uson. We are excited and we look forward to many more opportunities to learn as we strive and make Perpetual Succour Hospital Cebu Cancer Institute, which is the heart and soul of Dr. Tudtud, one of the best in our region. So our deepest gratitude for everyone who attended today's activity, and thank you for sharing your weekend with us. I know how precious weekends are. Diba, no?
Yes.
Yes. Thank you everyone who made this possible and who worked really hard to make this such a successful event. O wala mo, wala ni. Daghang salamat and congratulations. May hapon.
Mayong hapon.
Thank you. Let's have a photo op, ha?
Hello. So, di lang ko mag...
Yan pa siya galagaw.
Sorry for the technical difficulties and hurdles a while ago. We'll try to...
Pinana, ginaba sa online now.
Oh.
Let's open our videos, those who can.
Okay, and share. Everybody, para mag-attendance gini si Imi ko.
Attendance kay...
Sorry, ngani, this is how she do it in all our mga webinars,
Yes.
even in oncology. So, make sure that you are there because anytime there will be a photo shoot.
Yes, this is an effort of Cebu Cancer Institute Perpetual Succour Hospital, but we would like to thank MSD,
Yes.
the makers of pembrolizumab, for feeding us this afternoon, and also to Roche. Their immune checkpoint inhibitor is atezolizumab. Always we partner with great pharmaceuticals because without them we cannot do this alone. No? This is
We
a
can
partnership of everyone.
We have to thank also the residents, no? Our good
And
residents.
our interns,
And interns.
our nurses who are here.
Anang Laws here and Dr. Louis Lim here with us for the technical support and also the IM. Thank you.